Thanks very much. So it's William Bird. I'm a GP and also work in intelligent health. For Sarah, really, and obviously we're looking at those graphs and how depressing and how actually the life expectancy is, and the gap is getting bigger, life expectancy is starting to level off. And a lot of the input I've seen is all about adults, how we can sort out. But actually from adverse childhood experiences, we know that a huge amount of that burden is coming from children. And it's the problem that they've got in growing up in deprived areas. But I haven't seen anything where we're actually measuring adverse childhood experiences or whether we're actually dealing with that problem, because that's what comes through. And by the time we actually even see adults in their 20s, they've already got the inflammatory markers, they've already got all the disease things. So we're almost too late by the time we get into adulthood. So I was just wondering what plans from public health are for children.
I absolutely agree with you, and the focus at the moment is certainly on working age populations in a way that perhaps disguises some of the issues that you raise. But I think certainly from the health point of view, using those years leading up to entry to school, I think, are some of the most important things that we can do, and that comes back to some of the partnership working. So at the moment we measure how child weight at reception and at year 6, and we do tell families what the results of that are, but then we don't do anything else or have anything that helps them to address some of the challenges that information faces. And we don't use that information across our partnerships to be able to understand perhaps how we could make things better. So I do think school readiness as a metric is really, really important. I think the NHS needs to use it just as much as other partners to understand whether or not we're getting it right in those early years. Adverse childhood experience, trauma, informed care are all things we should be looking at. And certainly I know that the Children and Young People's Directorate in NHS England is starting to look at what those metrics might be in order to prioritise. So I agree it's not great, but I think we've got a way to go, but we are looking at it.
Thank you. Thank you.
Good morning, and thank you so much for the talks, which were very interesting on the long-term plan. My question is more on the movement from acute care to community care. And we've talked about the economic benefits of improving patient care pathways, improving population health, making a more productive society. But my question focuses more on the affordability aspect. How do we make this an affordable model? Because if you think of the hospital, why did the hospital exist in the first place? Because it's consolidating a lot of services in one location. So if we do move towards care closer to home, it means spreading that care out into the community. So what are the key strategies from your point of view that will make this an affordable model? Thank you.
Thank you. Yeah.
I don't know if you can hear me. I think, to me, can you hear me all right? To me, that's exactly what we were trying to talk about. I would love to see, and I keep saying I retired and returned about 5 years ago. I don't want to retire completely until every single person with a long-term condition is monitored at home. Because I think the only way we can make it affordable is to prioritise those that need that support and allow people who don't need that support then to carry on their lives and look after themselves and their self-care. And we can only do that if we can monitor them. So if we can't monitor people properly and know when they're beginning to deteriorate, we can't ever make it cost-effective, because we'll be looking at people that don't need to be seen. So to me, technology is crucial in that.
I'll ask Francis and then our GP to come in, please.
There's also the element here of thinking about how we can capitalise on a massive unused resource, which is people, their families, and the wider community. And if we look at the personalised care model, actually tries to encourage people to self-manage their own care wherever possible, increase activation, access peer support. I think we need to move away from the notion that we do everything to people, for people, and actually say, where can we be health coaches in terms of supporting people to manage their long-term conditions much better in the community?
Thank you.
Just to comment, I don't think this is to question the value of a hospital at the end of the day. These are environments which have a number of specialist resources and expertise, but what are they best for? Where they need to apply their specialist resources and expertise.
And so they should really work like factories. You should be able to go into hospital, get the treatment you need. I was just on a cab on the way here. He was like, and we were talking about this, and the cab driver was saying, I just want to be in hospital as long as I need to be, but then I want to be out of hospital. The reality is people want to be in their home environments, in their communities. And now, with the ability that technology can afford us, if we get it right, we can keep them and empower them to self-care where it's appropriate for them to self-care, and to provide them with expertise where it's appropriate to provide them with expertise closer to those homes. When I did my elective in Australia, people would go to the high street for their imaging. This is exactly where people want to spend time. They want to come to their GP surgery, they want to come to the high street because these are close to their homes. They don't want to go to the hospital, which is 15, 20 minutes away, particularly individuals that are vulnerable, have health inequalities, come from lower socioeconomic backgrounds, who can't afford to even get there. And so we have to utilise them for what they're best at.
We were actually talking about 10 years ago about kiosks in supermarkets where people could actually go into a kiosk and do a video consultation with a clinician in the hospital. And that was 10, 12 years ago, and of course nobody thought that would work. It wasn't until COVID that people realised that video consultation worked properly.
I'll just also remind you of Matt's very first slide that I put up around the pathway. What's the right care in the right place? And sometimes hospital is the right place. But the majority of the time, patients would argue that it's the community that's the right place for them. And the only people that put walls and barriers and silos in place actually is the system. The NHS puts those places in and says we're in secondary care or primary care. Patients just want care. So can we just remove the name and the barrier and just say we are a team of people who work together for the better care of the patient? And that would suit me much better. I think our time is up, but is there anyone with one final question for our panel? And if not, we will send you... we have one, so can I ask for this young lady in the middle, please? Thank you.
Thank you, and I'll be very quick. Sarah Parsons, I'm Health and Research Lead at HACT, which is the Housing Association's Charitable Trust. Nurse by background, but doing this now. So much to ask many of you. However, it might even be a yes or no. Looking at the... Gosh, I haven't got your glasses on, Sarah. My Care 24. Yeah. Do you see that this is something that could be applied to mental health? If we're looking at step down, we do a lot of working with housing associations with general health sort of issues, but also we do a lot working with systems, mental health patients, seeing mental health trusts who basically perhaps have 70% of the reasons that patients are delaying discharge because they can't get either into supported housing, some step down care. Do you see that this is something that could be used?
Absolutely, I do. And actually we work in a lot of learning disability and specialist care homes as well. And it's not with the Lucy app, actually, it's not remote monitoring, it's with the video consultation service. And absolutely, yes, it does work. You sometimes need carers there to support that person with the kit. I mean, that's all, it's just a laptop really, but yeah, there's no reason why it can't work for everybody. And this is why I'm so frustrated that that funding is so difficult to get hold of. We've done another 5 bids in the last 3 months because the money just isn't there to continue the services that we've already been developed and been running for the last few years. But yeah.
Thank you. Any final comments from the panel at all? No? In which case, can I first of all thank you very much for everything. Can I also note that we will be taking a 15-minute break now, and at the end of that break we'll be moving into the 4 different streams that hopefully you would have signed up to or checked that you wanted to be in, and there will be members of the team around to help you and guide you to those correct rooms for those stream conversations from, I believe it's 11 o'clock, but we'll say 11:05. Thank you all. Please enjoy the coffee break, enjoy networking, and please do speak to the conference people and the teams in the reception area. Take care. Thank you very much, everyone.